Hello, everyone, and welcome to the American College of Healthcare Architects Master Series 2.0. We have a great discussion planned today focused on a very relevant topic in our industry, behavioral healthcare and facility impacts based on current trends. My name is Daniel Perschbacher. I'm an ACHA certificate and a principal in the health practice of HMC Architects in San Diego, California. Joining me today as co-host is Angela Mazzi.
My name is Angela Mazzi, and I am a principal at GBBN Architects at Cincinnati, Ohio.
And now that you've met us, let's meet our panelists. Mardelle is a professor in the Department of Human-Centered Design, a member of the graduate faculty in the Department of Architecture, and the executive director of the Institute for Healthy Futures at Cornell University. A fellow in the AIA and ACHA, she has LEED AP, WELL AP, and EDAC credentials. Dr. Shepley has co-authored 6 books, the most recent of which is The Design for Mental and Behavioral Health. She has worked full and part-time in professional practice for 25 years. Frances Murdoch Pitts is widely recognized as one of the world's leading planners and designers of psychiatric facilities, and is a leader in the development of an evidence-based design practice culture in North America. He has consulted on more than 150 projects involving well over 20,000 mental health beds in clinical settings located in all parts of the United States and Canada. He has served as National Vice President of the American Institute of Architects and as President of both the AIA's Academy of Architecture for Health and the American College of Healthcare Architects. In his leadership positions in these institutions, he has advocated the development of practice cultures that evince evidence-based design. In recognition of his contributions to healthcare design, and in particular for his work for the mentally ill, Frank was honored by the Center for Health Design with their 2018 Changemaker Award. Hillary is a senior designer and healthcare planner who is passionate about behavioral health. She draws from the latest techniques in evidence-based design, best clinical practice, LEED, and plane tree principles to lead planning and design efforts through consensus building and dynamic listening. She believes in design with empathy to generate safe, efficient, healing environments that focus on the staff, patient, and family experience. Hillary earned her Bachelor of Environmental Design at Texas A&M University. Among her personal achievements, Hillary counts her receiving an architectural license, evidence-based design, and ACHA accreditations. She is also the current chairwoman for the 22 Kill Leaders in Construction Benefiting One Tribe Foundation, a nonprofit organization who provides mental health education and awareness for veterans, first responders, and frontline healthcare workers in Dallas-Fort Worth. Hillary is an advocate for behavioral health both in her work life and her personal life. She enjoys volunteering for a variety of charities, spending time with her family, and gardening.
And we're really excited to have our guests here today to really tackle this subject of behavioral health. So there's been a lot of trends lately in the research and design of mental and behavioral health facilities. So Frank, what do you see as some of those emerging ones that are really ones to watch that will help with early crisis intervention and focus more on keeping people out of the hospital so that they can have better downstream impacts in the care continuum?
What's been happening that has the greatest impact on diversion, Angela, is stuff that architects have nothing to do with. Really interesting involvements with schools, with programs in schools, with programs with school counselors that are meant to both destigmatize mental health and get people in for treatment as early as possible and to discover the mental illness as early as possible. But when we move beyond that, we're seeing a fairly rich series of investments in outpatient treatment programs and in structured intensive outpatient programs and structured day treatment programs. I think the thing that's been most surprising has been the development of crisis centers and the development of mobile crisis teams in community that are meant to find people who are in need of assistance, get them assistance at a crisis center without having to go through a traditional emergency department. And I don't think we saw an emergency department for mental health until 2008 for the first time. It has just exploded over the last 2 years. We have 3 large projects in planning and design at this moment. I'm understanding that we've gone from essentially 0 facilities to about a built base of somewhere north of 120 in the country today, and it's increasing.
And that has a profound impact, of course, on someone's ability to stay within familiar surroundings, hopefully develop more real life coping techniques, and avoid that hospitalization. So I know, Mardelle, you do a lot of work related to the clinician and the patient experience. What are you seeing emerge as things that we should really be focusing on, maybe more than we do as architects?
Well, to think about how we might respond to some of the things that Frank was mentioning, anytime you start developing a new prototype, we need to be looking at it, because all the first things out the door is what everyone is trying to copy, whether or not they know its effectiveness. So for example, empath, which is an emergency psychiatric setting right now, a lot of people are engaged in that. I'm hoping there's going to be a lot of research around that topic. But speaking more generally, I think that, so we've gained more tools as design researchers over the years, and some of them rely on technology that we didn't use before, like using biomarkers. If you ask somebody if they are stressed by some experience, they can express their perceived stress, but from a physiological perspective, they may actually not be reflecting exactly what's going on in their system. So use of those kinds of tools. And generally, I see what people would call post-occupancy evaluations. Anytime you evaluate anything, a building, in a sense, it's post-occupancy. But I think they're becoming more conscious of the potential impacts of what they're doing and the need to do no harm, the way any physician might want to do it. I would say I like to believe that we have been training young architects in this area of specialization to be more conscious about being accountable about what they're producing. So that's the general direction. In summary, I see looking at prototypes as they come out the door, engaging in technology, and more focus on evaluating the quality of what we're producing.
It's such a good point, Mardelle. Thank you for emphasizing the need to base our future developments and planning on the realities of what's been done before, and making sure that we're not just blindly following the most recent trend, but rather we're grounding ourselves in evidence and research, and making sure we're creating care environments for patients and suitable environments for the staff to keep everyone safe and healthy. So, Hillary, I'd like to go to you as we think about organizations planning for their next behavioral health facility. Frank mentioned the continued rapid investment in outpatient areas, but it's hard not to notice that these facilities are getting more and more expensive. And I would love to know how you, as a healthcare designer, a behavioral health planner, see ways that we can impact the increasing cost of the healthcare environment, specifically for behavioral health. And then related, what are any trends and impacts of reimbursement in the behavioral health setting? And how can facilities, as they're getting their planning off the ground, in addition to looking at the latest and greatest and best research, how can they plan for success around the sticks and bricks of the built environment?
Sure. I think one of the biggest things that we can do as designers is start by listening and asking good questions, and really trying to understand, the culture, the environment, and the local response to that. And the things that the questions that we ask, with expense, behavioral health can be more expensive when you're looking at ligature resistant fixtures, for example. A lot of times those are 2 and 3 times the cost of a standard traditional fixture. And so really knowing that and doing, putting some rigor into kind of really focusing on the areas that truly need that and not, going overboard one way or the other. Really working closely with staff to create flexibility in the environment. So lots of different types of spaces and opportunities that we can create spaces that are adaptable enough to be used for more than one thing, so that we can really look at creating that synergy, using the outdoor spaces as well as the indoor spaces as a part of that extension of the milieu, and really pulling all of those together. And, really for reimbursement's sake, there are a lot of challenges right now for behavioral health, for mental health facilities. And so, looking at where can we help them target, where can we help them target their changes there, and create opportunities for grants or other approvals? Are there things that we can go out and look at strategic partnerships within the communities to instead of building on site, maybe there's some synergies there. So some of that thinking outside the box, and how can we help them start to weave those pieces of the continuum together?
I'm curious, Mardelle, from your standpoint, as we look at planning the site of care for a future behavioral health hospital, what are some benefits that you see, whether it's creating a facility on an existing campus versus out in the community off campus?
So the thing about being on campus, there are some pros and cons to both these options, but being on the site, you are proximate to other health services, and they're very, I would say the majority of people with mental health issues also have physiological issues they're dealing with that might have to be treated by other parts of the health spectrum. So that proximity is helpful from that perspective. And also you have staff that's sited there that can maybe move about more quickly if they were trying to work with that population. And there's a little bit of, so these health campus settings are sort of stand out as sort of landmarks for the community in terms of where health happens. So that's a positive side that people would put on that. Taking it off campus, particularly if you're going to push it out to the community, having this health service in the community where people can actually go there, be treated there, maybe circumvent the more in-depth medical system by being triaged early and being able to sort through what their options are as alternate care. Like having that in the community is good. And then there's when you're in a less institutional setting, the quality of the experience from a visual, from an architectural perspective, you can scale down the institutionality of it more readily. Not everyone does that. Sometimes they build these very pristine and sterile environments and beautiful pastoral neighborhoods, but you generally are able, if you're going to be contextual, you're going to have the opportunity to create this nicer experience in the community. So I don't know how you feel about, I know you're going to Frank next, but I probably has some opinions about this.
Should I wait for you to redirect the question to me, or should I jump on Mardelle's invitation?
No, go ahead, because I know you've done it both ways, so we'd love to hear your insights.
So
I had fun. I just wanted to bait Frank, so that was a bit of fun for me. Go, Frank.
So, this is not for an architect to decide. It's for an architect to be sensitive to. We had a project recently. It's actually a fairly well-known project, Nationwide Children's Hospital, where the idea of doing it on the campus was central to the hospital's mission. The stigma question was important to them. They wanted the mental health pavilion to appear just like any other pavilion on the campus. They wanted it integrated. They didn't want to go out into the suburbs to do it. There were some efficiencies in doing it on the campus. You're not having to reproduce support service and clinical facilities within the mental health hospital if they're also available elsewhere on the campus. And so there's some efficiencies there. There was some efficiency in doing some of the outpatient programs inside, Because it was easy to do a transition post-discharge into an outpatient setting. It's frequently you get higher level of compliance post-discharge when a patient gets to go to the outpatient setting, especially if it's an IOP or a PHP, intensive or day program prior to discharge. On the other hand, that same facility had a ton of outpatient facilities that are in the community, and that's where they belong. Generalized services should really be provided as close to the home as possible. But some things actually benefit from being collected together, especially if something like research is going on or neurodiagnostic techniques are being used or neurostimulation is being used. And I would say that continuing to show these facilities as always separate actually is going to get in the way of getting neurology more actively involved in patient care and treatment. This separation of psychiatry and neurology is something that dates back to the late 1800s. It relates back to a food fight between two medical disciplines. And the pervasiveness of that food fight to this day is a great shame in American medicine. There are services that neurology can provide and should be providing to psychiatric patients. That'll only happen if we're co-locating on medical center campuses. So there's advantages. So it depends. What's the nature of the facility that you're providing for? For some, it should be in the community. For others, it should be central. The other interesting thing about Nationwide, though, was that the building type, the mental health building type, generalized has a very different form factor than a small site that you'll typically get on a medical center campus. And when we were selected to do the project, the board team that selected us took us aside and had a conversation and said, are we making a mistake cramming something that wants to sprawl a little bit and be lower on this site in the city, this small site where you're going to end up going vertical? And it was a really interesting question because you do have more flexibility to sprawl and be a one-story building or a two-story building on a suburban site away from the medical center. You can't do that easily at most medical centers or general hospitals. In their instance, we worked on figuring out a way to configure the building so that you could be on a compact site and take advantage of the interconnectedness and the reduction in stigma. So it's a complex question. Mardelle.
I'd like to add something to that. As designers, we are prone to copying outputs rather than, as Con said, for originality, go back to the origin. What are the design goals and designing to those rather than say one location is better than the other. If you all follow that, I'm sure you do.
Absolutely. Thank you.
I love these discussions because there's just been such a lack of care and lack of resources for this patient population that I think being sensitive to having a broad spectrum of care is really critical in making sure that they have the access they need when they need it. But I also think being able to have that multidisciplinary approach when that's appropriate can also be a real game changer for these patients. So when we think about this whole campus thing, on campus, off campus, what should we really be doing in these cases? I know there's definitely a shortage of staff, shortage of resources. What are you seeing, Mardelle, in your work as things we need to do to support the caregivers and the clinicians in a behavioral health setting?
I think all the assessments that we're doing in terms of occupancy evaluation need to cover all players. And although I have found in the studies I've done that both residents, we're talking about an inpatient setting, both residents and staff, they see the same things as being important. And top of that list is safety. Safety for staff, safety for patients. their perception, they see it as being equally important, the two groups. At the same time, they may perceive its effectiveness differently because people that are being served are not always privy to all the activities that are going on in that space. One other important difference between those two populations is that staff are there for extended periods. In the studies that I've been involved in, it's more common that a patient or resident will be there for, say, a month. And the way you imagine and interpret your environment or thrive from your environment will transition depending on how accustomed you are to being in that space. And that speaks to trying to provide some level of flexibility in terms of what the experience is. So that can transition it can be malleable. You can transition in some way that will be of use to those populations. And one of the places where the transition happens naturally is in outdoor environments, because the outdoor is continually evolving. That's one of the reasons people attend to that so much. They're not looking at unless they're living someplace where it's all palm trees and sand, they'll see a seasonal variation that is sort of enriching and also helps you create a compass within yourself because you view the world in the context of seasonal change. So that is something that enables people to feel more comfortable. So I'm going off in a tangent now. So you can rein me in and bring someone else in on that.
Important to have those resources so that the stress of dealing with this difficult population can be alleviated. What other kinds of things besides outdoor space really are making a difference for staff?
If you're addressing that, to me, I asked staff what was most important to them, and because there's a list of things, I'm going to read it for a second. Well-maintained environment, visual access to nature, attractiveness and aesthetics, deinstitutionalized environment, and an orderly and organized environment in that order. Well, those is what I would call qualities rather than specific spaces per se. But when they looked at specific features towards the top of their list, apart from staff safety, was noise and light, which has a huge impact on all of us. And to my knowledge, there is little or no research on the impact of the acoustical environment on the staff or the patient experience. And certainly staff who are subjected to it on a regular basis, it's going to be, and for a long-term basis, it may be even more profound. You don't actually become accustomed to it. You're just able to filter it out in some way.
Yeah, those are great points. Hillary, what are you looking at when you think about designing for the clinician and the caregiver?
You know, when we're creating these environments, I really try to focus on design with empathy. And I think that, so we tend to start to, pull people into groups and look at, okay, well, staff might need this, and residents might need this, and patients might need this, and family members might need this. But looking at the common element, we're all human, and we have so much data and so much information about all of how our brains work. We have a lot of information about the types of things that can bring people calmness and respite and peace. And I would like to see us moving completely towards using and embracing all of this great information about how to make people well, and really using that across the board. So not just in behavioral health environments, but looking at waiting spaces everywhere, looking at, our caregiver spaces everywhere, and not caregiver sense in the form of staff, but also family members, and really, providing multiple environments for people to move through their days and move through their individual experiences and cope with the stress that is created. Unfortunately, caregiver burnout is huge. Staff burnout is huge. Retention, all of those things, because this type of work is very personal. And so people, it goes through, you run through a lot of emotions. And so I think it's really important that we are grabbing onto those things about the outside, all of the wonderful things that we know about daylighting and access to nature. We know that, when you're having a bad day, sometimes you need a space to go and shut down and really recharge. And so providing those environments, providing, what Mardelle was saying about the well-maintained spaces, that's a signal to everyone in that space that someone cares, that we're taking the time, we put stock in this environment, and those things matter. And so I would say that when I'm creating anything or working with any clients or patients or whoever I'm working with, that those are the kinds of things that I think back to what helps me, and asking that, engaging them in that conversation and helping them say, okay, well, let's talk about your days. What is your standard day? What is it that you need? Do you need some offstage space, some private space? Do you need adequate space to kind of peel off and have a conversation, a quiet conversation to de-escalate a patient? Something as simple as that, as having an alcove or areas like that, that really changes not just the mood of the patients and how they're responding, but the staff too. And the staff are able to give better care when we're able to support their needs as humans.
Hillary, it's beautiful to hear you talk about how impactful the interior environment can be and is, both on the staff and the patients. And it makes me think of one of the previous topics. We talked about the importance of having a safe environment, obviously, how important that is for the staff. And Mardelle mentioned a word earlier in the context of outdoor spaces. Because of their ability to change over time, they automatically create a flexible interior environment. But I wonder, from the care standpoint, it's really becoming more incumbent on organizations to build a very flexible chassis to accommodate a lot of different patient types, and whether that's different diagnoses or different age cohorts. What are some of the strategies you're seeing, Hillary, that facilities are taking to create a safe environment, an appropriate environment, that every month may be seen in certain areas of the hospital, different patient types that really do have different needs?
Oh, I think using the therapy mall concept, where you're pulling some of that, you're aggregating some of those therapeutic spaces like group rooms, classrooms, any type of physical activity, those kind of things. If you can pull those to where they're accessible from multiple sides, that can create some real synergy for different types of populations. We can certainly control those things with scheduling. We can control those things with access, and that can help to kind of extend that. There is a trade-off for that. That means that those patients are moving from one environment to another, which does take some staffing there to move with that patient, to do it in a safe manner. But I think, visibility is another really key element to safety and security. Knowing your patient and being able to kind of just scan your environment and see who is all there, that is helpful not only for the staff and their safety, but also for the patients. That can actually really make patients feel more safe and calm when they can actually see that they have caregivers out there and kind of know their environment. So I think that, there's a lot of tools that way that we can use. Some of the strategies we've used on more inpatient units is being able to create those smaller groupings of patients for the bedrooms. But then if they're not going to be using and having access to their bedrooms all day, then is there an opportunity to kind of shut that wing down so that the staff is not having to worry about monitoring those areas? So doing some strategies like that, I think, can really help.
Yeah, I love that idea of using spaces for multiple purposes. So you get these therapeutic spaces, you get them in an area that is accessible by multiple different units. That could, in theory, allow units to flex spaces more fluidly. But as you said, there may be some potential drawbacks. There may be some additional staffing concerns now that we're moving patients more than we would in the traditional, more static inpatient environment. Frank, I'm curious, similar question for you. What are some of the strategies you're seeing in your office with your clients designing flexible spaces for the inpatient environment to account for multiple different patient types?
I tell you the number of times we have designed something that was explicitly meant to be used by a particular population, where 2 years later it was being used for a completely different population. So we've been doing a bunch of work around template units, units that have enough flexibility that they can be reasonably expected to serve a variety of patient needs. But you have to be careful, because some of those can have an implication for size and cost. If you really mean a facility to be used by a geriatric population flexibly, then you're really talking about a commitment to a larger amount of space for maneuvering, for chairs, for scooters, for all manner of things. So you can't just willy-nilly do it. You have to have a conversation with the client about what level of flexibility is worth investing in. But a ton of flexibility has nothing to do with extra space. A ton of flexibility has a lot to do with something Hillary was talking about a moment ago, the human experience, and what it's possible for a human to reimagine in terms of the use of a space. So we've done something recently where we had suggested that we had seen lounges be used in or living rooms be used in crisis centers, and this client said, "Yeah, let's do that." It wasn't a lounge model, but let's do that. And in the feedback retrospectively, we found that clinicians are actually using lounge, which had been seen as a patient resource. They're using it as something that augments their therapies. A story was told about this young woman who went to this hospital, and the clinician wasn't getting to her, couldn't figure out how to make a connection. He noticed that she was a cheerleader, and he said, "Hey, let's go over to this lounge, and why don't you show me some cheers and talk to me about it?" And it was brilliant. We think mechanistically about what clinicians do or what staff does. We don't think about it as a human activity. And I'm banging on Hillary's drum here, which has been my drum for a long time. We focus on the role rather than the common human thing. And so if you design a place where staff can see a range of patient activities in a range of different settings and different groupings, you're actually going to get to know and understand that patient far better as an individual than if it's just these two rooms, this same group of people all the time. That's not actually efficient in the longer term in terms of understanding where the patient is in their journey and what you can do to help. It's also not good for the patient. A lot of treatment really has to do with developing self-awareness and introspection and gaining skills that come from that. Again, you need to be in an environment where you get to test and experience things in a variety of ways. And that's not the old-fashioned traditional psychiatric hospital. Those kind of features actually really do help with staff satisfaction, because the building starts to be a part of their toolkit rather than something that they're fighting against. I want to do a Me Too on Mardelle's question in terms of the question you asked, Mardelle, in terms of supporting staff. It used to be that we were always doing 120 to 160 square foot room that was the staff lounge, and it had a toilet next to it, and it had a little locker room, and it had a crappy little kitchenette. Those days are over. We're doing huddles. We're doing far more desk space and working space in inpatient units than we ever did. We're doing much larger staff lounges. The toilet room isn't necessarily on lounge. The locker is not necessarily on lounge. And those are on the care floors. We're also doing special staff amenities and outdoor space on other floors of the building to an extent that we've never done before. We're also being asked to provide way more space on unit for training because there's this critical need for staff. And so a lot of facilities are paying a lot more attention to onboarding and training, including training folks that are still in school. And that's having an impact on the size of facilities and accommodations.
Mardelle. Okay, if that's okay if I build on what Frank was saying. I think that some of the things that I found when I've done these post-doc evaluations is very often the staff space is undersized relative to the need because the inclination of the project team is to provide for the patients first. And I totally appreciate that. But I've seen in many cases, and one in particular I can think of, not in a related building type, it was one of the original facilities for persons with AIDS. They had 4 beautiful atria, 2 at the end of each quarter of 2 floors for patients to recenter themselves, so to speak. Staff just did not have enough room to do their activities, so they had to usurp one of those atria in order to carry that out. So it's trying to achieve that balance. And I think I'd love to hear what Hillary and Frank, what their thoughts are about these sort of verboten subjects of shared versus private rooms and open versus closed nurses stations. Because when I think about being flexible, I'm thinking less about this diagnosis versus that diagnosis, in part because many people have multiple diagnoses. But how maybe potentially volatile the population is. Can that nurses station be open? Can it be transitional? Can it be closed? And when you put patients in or residents in their rooms, do they need to be accompanied? Or are they better off on their own? So if I can go off track a little bit here, I'd love to hear what Hillary and Frank have to say about that.
Sure. Frank, would you like me to go first?
Sure.
Okay. So I feel like we're hearing more and more that private patient rooms are the way to go. I will say that there are some specialty populations, and actually Frank and I were discussing this at a recent conference, but like veterans. Veterans are a unique population in which they're in the military, in their service, they develop a family, and that becomes their family, basically. And so there are still a lot of those kind of populations that and that benefit from having a buddy in their room. But for the most part, another thing to consider is the complexity as human beings that we are. There's medical needs, someone who sleeps with a CPAP, for example, just those little things like that can actually impact the care and the recovery of someone else in the room. Just having your sleep, my husband used to have one, and it would keep me awake. It was not something that was, but it's just those little things like that. I think a new thing that, we've run into more and more frequently is gender separation. So traditionally, there are still many places that require a gender separation. There are absolutely a need for that in some cases. If someone has had an attack or a trauma, yes, those are populations that need to be protected. But there's also, and I can tell you this from experience with my own children and just watching my own children grow, that gender fluidity and sexuality fluidity it's growing and changing very rapidly. And so a lot of those, there's some issues with the shared spaces or having that true separation of a female unit and a male unit. Well, what happens when you don't fit in that? And there's a lot of people who don't. And so there's, you can control some of those aspects with that single private room model. And for the staff stations, I can say that a lot of times what we're doing is doing the open model, providing those spaces, but then having the backup space right behind it to retreat to for safety. So are there conversations you can have and kind of that mix that you don't have to have it only one way? Is there a way that you can kind of take the best of both worlds for those reasons?
Yeah, I think the questions get presented as though it's a zero-sum game. And Hillary's right. It's not a yes, no, open versus closed conversation. There are a continuum of ways of meeting that need. And what we've taken to do, and I think Hillary was there for when we sort of invented the tool, is we've said, here's a range of open and closed stations, and why different people, including facilities that have no staff station, and why facilities considered where they position themselves along this continuum. And then that actually facilitates having a more nuanced conversation about finding what really is the sweet spot for that facility, or even suggesting something to their own mind that never existed before. What do you mean, no nurses station? Fascinating. Children's facilities, there's been an uptake in that I had never seen before. It was children's facilities that first came to us and said, no, we don't want a care desk. It's not us exporting it. It's us just showing what people are doing and then asking what's right for you. On the private bedroom front, we've assembled a bunch of data. We've worked with over 100 architects across America, and we by now have not just our own data, but data for bunches of other practices. And there is a profound uptake in percentage of private bedrooms or percentage of hospitals that are fully private. It's profound. And particularly profound, I'd say, over the last 6 to 8 years, well over 90% of the commissions that we're getting or that are in the data set are that way. There are particular types of providers that are not that way. And you have to understand when you're dealing with those providers why they're not that way and what the rationale is. But as Hillary says, when you get to a veterans population, yeah, it's a different question. Sometimes when you get to a seniors population, it can be a different question, but you have to ask yourself, while you're hearing somebody say it's a different question, you have to ask yourself, well, if that's the case, why do all of the advanced skilled nursing facility models generally migrate towards all private bedrooms? Are what we're measuring around senior citizens and mental health really a measurement around a socioeconomic circumstance rather than something that is related to their geriatric status? So enough of that for now.
I love this discussion. Did you have more to say, Mardelle?
I did. I wanted to know, again, this is sort of a difficult subject, but we in the United States can take this initiative of creating private rooms. What about parts of the world where that becomes a spatial luxury? Do you have any thoughts about how that population might be managed, or any perspectives on what advice we give to developing countries?
Oh, gosh.
I was so to give a little, for me, the private rooms, we want the private rooms because we want people to be able to maybe control their environment, maybe. I'm trying to think of why is the private room good? So if I sort of tunnel back, it's probably a sense of choice and control if you're on your own. And that could be whether you keep the window open and closed, or what art you might have on the walls, assuming it was in a secure situation. So how do we in these other settings increase opportunities for privacy? So maybe it becomes something like There are shared areas within a small number of specific areas that you can access on your own, be alone. So it just force ourselves to, yeah.
So Mardelle, I think it reminds me of, to me, I go back when you raise the question this way, and it's in a context where there's not enough to go around to give everyone a private room. And I suspect that we're back to having a conversation like the ones that we had 40 years ago when we were doing mental health facilities, when we were moving from dormitory spaces into something that affordably felt differently, which in an interesting way was happening simultaneously in college and university dormitory settings, where we were moving towards thinking about, how do I do a double that's a double, where the individual student has greater control and privacy? What are the form factors that evolve? And there's a really rich body of work that we can imagine and could do around how to take those large anonymous spaces and create things that are still congregate, but don't feel like they're fully congregate.
What you make me think of is, because I'm on campuses all the time, and there are a lot of similarities between behavioral health facilities and dormitories on university campuses. I mean, I say that in just in part, but in part not. We're trying to find not just what's good for people in a behavioral setting, but it's good for all people in all settings where they may cohabitate. So thinking of this as sequestering it off in the behavioral health area doesn't take advantage of our opportunity to share our findings in this specialty with other fields. I mean, it could be correctional, it could be education, it could be any other kind of institutional environment or any kind of residential setting, all those things. So these are the topics that are coming up here are really relevant to many typologies. And so
I would also add, you know, I would be really curious to have the cultural overlay of different countries as well, because like the veteran subpopulation, you know, there may be other groups that culturally that may be comforting versus the opposite. So I would be really curious about that.
I think that's been clearly demonstrated. There's some places where if you told people they're going to be in a room by themselves and be sick, they would find that to be a terrible option. They would rather be in a group with the community. So
my daughter's like that. Yeah.
Well, there you go.
I'm loving this conversation because there really are a lot of equity issues involved as well, and things that really matter. And Frank, I know your work delves into regenerative design as well. So what environmental features do you feel really most help to empower both the patients and the staff? And I know we've talked about things like the environment being in order or access to the outside, but are there specific design strategies or adjacencies or flows or program elements that we should also be considering as part of that regenerative design idea?
Well, things that I think are proving to be helpful are some are just gestures and gestures that just take a little bit of space. So the idea of there being a celebration of movement from a hallway or a congregate space into the private bedroom is actually something that is really worth a whole lot more than just a door in a corridor. That's a transition that's kind of important. In particular, if you're living the whole rest of your day with a group of strangers. The ability in a larger living room environment, for example, to be able to find a place at an edge or in a corner or in an alcove where you could go and be in the room but not be right in the middle of everything, or to have a meaningful choice of where to be in a room, or the idea of there being, I'll call it a place in between, something that doesn't exist in a program, where I could be somewhere near a care desk as a patient. If that were to actually be more interesting to watch what's going on, or more interestingly important in order to understand who are my caregivers and how are they with other people, or maybe I feel safer in a place like that. Those kind of places in between where you can appropriate them and use them, that aren't necessarily program places, are I think valuable and important. The idea of subclustering that Hillary was talking about earlier is an idea around building not just a set of bedrooms that form a suite, but really looking at the college dorm model, where those suites have their own support spaces, their own, sometimes a kitchenette, clearly their own living room. That's really been an interesting model in terms of what the social sciences talk about, in terms of social density and spatial density, in terms of reducing aggression by having people in smaller groupings where they work it out. We have a tendency to work it out where it's in a smaller group. That same strategy actually has been really important during the pandemic, in terms of management of disease management. And we've seen people use it. It's also something that we're finding is relatively flexible, in terms of bed assignment based on cohorts. If you've got somebody, if you've got a group of patients who may have been traumatized in a particular way, you might consider cohorting them into one of these small subclusters. You might not have enough of them to build a whole unit. But so we've done that in Worcester. There was a group with a high degree of deafness in the Commonwealth of Massachusetts, and not enough to drive a whole inpatient unit, but enough to drive an 8-bed or 10-bed subcluster that was designed for folks that were hearing impaired. And then finally, the idea that Hillary was talking about the treatment mall. A lot of short stay patients, there's not really an opportunity to get off unit to go to a treatment mall. But in a long stay environment, the idea of there being different kinds of environment over the course of the day, that you leave the inpatient unit and you go to a treatment mall that's within the span of control of the direct care staff, can be a really valuable thing in terms of a different kind of a place and a different kind of an aggregation of people that you're together with during the day. I'll stop there.
Hillary, what are you seeing in that vein?
Just building off that kind of treatment mall concept that Frank was mentioning, some of the techniques that we've done before are using, creating kind of a great room concept. So when you do have large numbers of people, large groups, and you're kind of spilling out into the hallway, well, that's a really big, opportunity for some aggression or some, anxiety, some different feelings. And so it having like this kind of spill out space, almost an extension of the corridor, but that could actually be used for activity space, or, to come out and sit down and, have a few minutes to reorient yourself before you go to your next, your next session or your classroom, things like that. So we've been playing with that some. Let's see, some other things, those elements of the residential life. And, that's the whole goal, right? Is the goal is to get you better, to help you through your transition. Because, we all know recovery and health, all of those things, it's not stagnant, it's a process. So every day and every moment we may feel or go forward or one step backward or everything else. So really thinking about that as a transition and moving through that. But just we're trying to get you well enough to go and live in the community. So anything we can do to start setting those those environments up, and then testing, allowing patients to test themselves, like Frank was saying earlier, in a supported environment. So those subclusters, those kind of living room and kitchenette and all of those things, are those ways that the patients can test themselves, but still have the support of staff there. The overnight training spaces, especially for pediatric populations, is something that has been mentioned a lot more recently, and that we're kind of looking into. So is there an opportunity for a family member to come and stay if they have a young one and they may be a little nervous themselves about having their kiddo come home and being the full-time caregiver at that point. So, like we do for NICU moms or NICU families, where we have a overnight kind of transition where they have staff support, they're there in that environment, they can kind of get their feet under them before they transition home. So those are some different things that we've seen and been hearing lately, and really playing with.
Yeah, and I think that really helps to create that confidence and that assuredness that you have the resources to cope while help is still there. So those are really great amenities to provide in this space. And I think that ties back to what Frank was saying as well, that the amenity matters because it is about experience. So we'll finish up by having you weigh in on this, Mardelle. What do you think is really something that can help with this? What amenities are really valuable for patients and staff to have?
I think most of the things that have been mentioned previously cover a range that I think gives people enough inspiration to move forward. I've been lately looking at, of all scary things, the impact of color. It's the most debated topic out there with regard to design, and trying to look for strategy of do no harm and some sense of where some things might be appropriate and other things might not be appropriate. So for me, because of my specialization, I'm looking to where research might be turning next. And again, this is sort of the socially responsible perspective on what's happening, what people like Frank and Hillary are putting forward, how I can serve to support them or to provide them confidence in terms of what they're proposing. So it's more contributing to the process, so thinking about the process than thinking about a particular product.
Well, we'll end it here. On behalf of Angela and the rest of the healthcare community that has joined us online, this has been such an inspiring conversation for me to participate in. I want to thank Mardelle and Frank and Hillary for coming on and sharing your insights and your expertise and your experience working in such a critically important care type in our industry today. So thank you so much for your time.
Thank you for having me.
Thank you. Bye all.
Take care.